I believe that the discomfort with end-of-life discussions comes from the fact that none of us want to die. That's an obvious answer, but I think it's the truth, and it somehow gets overlooked in lots of discussions.
What I would like to say to people is that we have learned so much more and are doing such a better job of providing comfort care to individuals that there is such a thing as a good death, a comfortable death, and we have the ability to provide that to their loved ones.
If a family member ends up in the intensive care unit, I think it is essential for their family members and loved ones to be their advocate.
No one chooses to talk about death. Death is not a pleasant topic, and obviously, if possible, we would all choose to avoid it. But there are certain realities of life. Aging, eventual illness, and death are inevitable processes that cannot be separated from life. Yet we work very hard to avoid confronting this reality. Even when faced with an illness which will certainly limit the time we have left with our families and loved ones, most of us would choose to avoid the difficult conversations about death and dying. Unfortunately, this leaves us unprepared for the decision-making at the end of life which critical illness demands. When a loved one fails to respond to treatment in a hospital's intensive care unit, a family will face tremendous uncertainty and a terrible sense of impending loss, while at the same time being asked to make very difficult decisions about continuing or withholding life-sustaining therapies. Without help, we can easily allow ourselves to be overwhelmed by such challenges. But while dealing with end-of-life issues in the ICU is always bound to be difficult, there are practical steps that we can take to make this transition easier and more comfortable for our loved ones and ourselves. Hello, I'm Dr. Mitchell Levy, Associate Professor of Medicine at the Brown University School of Medicine and Chair of the Robert Wood Johnson Critical Care End-of-Life Work Group. In this video, created through a generous grant from Orthobiotech and in association with the Society of Critical Care Medicine, we will hear from prominent experts on end-of-life issues. They will discuss the many complex decisions faced in the ICU and talk frankly about how we can better cope with end-of-life issues. They'll talk about the importance of advanced planning, communication with physicians, answer questions surrounding the withdrawal of life support, discuss the issues of pain and symptom management, and outline the goals of compassionate end-of-life care. It's our hope that we, as medical practitioners, can offer you some of the tools needed for dealing with life's most difficult transition. We will begin by hearing about the current state of intensive care treatment in America's hospitals and look at the potential barriers to compassionate end-of-life care in the ICU.
There's been a lot of attention recently to end-of-life care in general, and there have been a number of studies recently that have shown family dissatisfaction about end-of-life care in the ICU. I don't believe that this is a new phenomenon. What's new is that people are looking at this. This has become an important issue to physicians and nurses and hospitals, and there's been more research in this area to show the dissatisfaction.
Many concerns have been raised about insufficient communication and lack of attention to effective pain control and symptom management. I think it's highly appropriate that the public is engaging at this level to help us try to improve end-of-life care.
I think the public is very concerned about the care that they receive at the end of life. I think that many families perceive that their loved ones are dying in pain. I think they're worried about being abandoned, feeling as if they're being abandoned, and not having the kinds of support systems that will help them to get through that process in a way that they can have some meaning associated with it, and also that they can maintain a sense of integrity in the process.
And I think the quality of this care is improving. There's a growing realization that this is an important area, that we need to provide good quality care, not just to patients who go on to survive, but to patients who die.
There's better public recognition, there's greater professional recognition that our care is less than optimal, and a great deal of effort is being put into promoting better care practices for dying patients and their family members.
I think the barriers to good end-of-life care are many. Some of them have to do with the systems of care where people are being cared for at the end of their lives. Many people still are dying in hospitals, and we know that there are alternatives to that. I think one huge barrier is just public and professional attitudes, that we are very much reticent to speak about the reality of death. And as a result of that, we haven't had conversations either in families or with patients and their healthcare providers.
I think from the standpoint of families and patients, the greatest barriers are those that are created by their own relative unsophistication about disease and death, and by the comparative sophistication of health professionals, but the inability of health professionals to discuss these issues at the level of the patients and the families.
The intensive care unit environment can be a forbidding and frightening place. It is full of machinery. It is full of complex medical issues that are hard for people to understand and frightening to watch. And this may make it difficult for people to feel comfortable in dealing with what is one of the most private and difficult moments in a life.
At the same time, I think there's a barrier in the sense that many patients and families have expectations about what medicine can do that exceed our ability. At the same time, I think physicians and other professionals have great expectations themselves, but often the expectations, if not great, are less than what families and patients have. And I think people have a hard time getting on the same wavelength so that they can be realistic about what therapy, such as the intensive care unit, can bring.
Patients who are seriously ill cannot talk to the caregivers. We cannot talk to them directly. We're often going through family members, next of kin, surrogates, alternate decision makers, and that can be very difficult because we need to try to understand what patients would want if they could speak for themselves, and that often gets mixed up in what other people would want for that patient.
I think the most significant barrier to good end-of-life care is communication between family members and clinicians, both physicians and nurses. The care that we provide is often very good, but if we don't communicate well with patients and family members, they don't feel like they're getting good quality care. So I really think that communication is a key.
I believe that patients and families need to realize that when a patient is in the intensive care unit, it's because he or she has a very severe illness that he or she may not survive. In fact, there's a mortality associated with being admitted to the intensive care unit that ranges as high as 20% in some medical series. So patients and families need to know that anybody who's ill enough to be in the ICU has a distinct chance of dying. At the same time, they need to know that in the intensive care unit, generally speaking, physicians and nurses and other practitioners are going to do all they can to help the patient recover from the illness, until perhaps a point is reached where recovery is impossible. And at that point, the intensive care unit therapeutic trial is going to be judged a failure from the standpoint of the professionals. And they're going to approach the families and say, or the patients, and say, we don't think things are working out. We believe that care should be withdrawn at this point. Now, ideally, with good communication between the practitioners and the patients and families, if that point does arise, it's going to be obvious to all concerned, and they'll be at a common understanding level so that this doesn't come as a great surprise.
Given our reluctance to discuss death and the possibility of dying, it should come as no surprise that families often have a limited, if any, idea about what level of medical care their loved one would want as their condition worsens in the ICU. Advanced directives and advanced care planning reflect the level of care desired by a patient when faced with severe, possibly fatal illness. Unfortunately, few patients have given much thought to these issues before admission to the ICU. Yet when available, these directives can be very helpful for guiding care at the end of life, when the type of care that can be provided can range from aggressive, invasive therapies to measures intended to provide only comfort.
These are issues that we're all going to face. We're all going to grow old. We're all going to get ill and die at some point, and that it's very important that we talk to the people who are important to us about the kind of care we would want if we got too sick to speak for ourselves, and about the kind of care that our loved ones would want if they became too sick to speak for themselves.
I think it's essential for anyone who can anticipate death, and that comes at different ages to people, but certainly most adults can anticipate death, to give thought to what they're going to do in the event of a critical illness, especially considering that a critical illness such as trauma may come out of the blue. It's easier for people with chronic diseases, but everyone should think about this because everyone could be traumatized in a society such as ours.
It's difficult to plan for serious illness that occurs suddenly. But what one can think about is what is an acceptable functional state? What is an acceptable quality of life for me? And how will the decisions be made if I am seriously ill? Who is going to make them? And what are going to be the operating principles that they use to make them?
One of the opportunities that we have when we are able to talk about the issue of end-of-life care is that gives us the opportunity to do some advanced planning, to have conversations in families about what preferences people would have about their care at the end of life.
Living wills do not solve the problem of what kind of care you want at the end of life. Living wills are a single piece of paper or a single document that tend to be very general and don't help physicians and family members make specific decisions in specific scenarios. I think it's far more important than signing a piece of paper called a living will is having the conversation with your loved ones and with your physicians about the kind of care you would want if you got too sick to speak for yourselves.
The most important thing that one can do in advanced planning is, number one, to identify someone who can speak for you if you are too ill or impaired to speak for yourself. This has to be someone who knows what kind of person you are and how you feel about medical care and about the quality of your life and what is acceptable to you in terms of a health state and a functional state. So the most important aspects of advanced planning in my mind are the identification of a decision maker, a proxy, to help speak for you if you can't speak for yourself, and then communication with that person about your own preferences and thoughts about quality of life and acceptable health.
Even when faced with a mild illness, like the common cold, many of us feel isolated and alienated from the people around us. Consider how much this must be magnified and exaggerated for the person who is dying and their loved ones. At a time when nurturing and human kindness is most needed, genuine communication between caregivers and patients as well as families motivated by compassion is often lacking or inadequate. This can only serve to heighten the feelings of loneliness and isolation that is so common to the dying process. What can be done about this unfortunate situation?
I think the public needs to be much more active in sharing their preferences with healthcare professionals. I think that every American ought to expect that their pain and symptoms are going to be treated appropriately. I think that every person ought to expect that their healthcare professionals are going to listen to them and engage them in trying to create a plan that will honor their values and preferences. And if we have family members who are aware of those options, then I think we can really begin to have the kind of dialogue that we need that will promote the very best care for everyone at the end of their lives.
I think the most important thing for public to ask of clinicians during end-of-life care is good communication, is keeping the family up to date, current about what's going on, making sure that the family understands the prognosis and the treatments that are being used, and when decisions are made to withdraw life-sustaining treatments, making sure the family understands what's going to be done to ensure the patient's comfort in the final stages of their life.
I think that the public should expect that their wishes about end-of-life care should be heard by clinicians and should be respected by clinicians. I think the public should be expected to be actively involved and to be able to communicate with clinicians about what their needs and their loved ones' needs are and if their needs are being met. I think communication among these people is absolutely essential and will provide, good communication will provide comfort to the family members.
As we have already said, talking about death is very difficult, not only for patients and their loved ones, but for ICU clinicians as well. As a patient or family member, how do we ask for help? When we need more information or when we want more support, what can we do?
End-of-life discussion should be initiated by anyone, and in particular, one party, the patient or the physician, shouldn't wait for the other person to bring it up because they may never get to it at all.
If you ask patients who should initiate these discussions, they say physicians should. If you ask physicians, usually they say the patient should. In my opinion, I think it's very important that both sides be initiating this discussion. When patients or family members feel like they'd like to talk about these issues, they should feel comfortable bringing it up to their physicians. In some of the research we've done, we've had patients tell us that they're uncomfortable bringing it up to their physician because they don't want to hurt their physician's feelings. And I'll tell you that it doesn't hurt physicians' feelings to talk about end-of-life care. I think it's an important thing to bring up.
Ideally, end-of-life discussions would be occurring in people's homes between patients, their family members, among family members, with family physicians in their offices before people become seriously ill. Too often in the intensive care unit, for the first time we're embarking on these discussions.
But if we lose the opportunity to have these discussions among the family members and providers, then we may be caught up short at the end and not be giving the family members the time that is needed to resolve some of the issues within the family.
So it is almost always appropriate to initiate some kind of discussion about prognosis and about appropriate and realistic goals of care. And that should be done by physicians, but it's certainly an appropriate area for a family to initiate if they have questions or concerns.
When confronted with critical illness, some of us may eventually face the agonizing and devastating decision about whether or not to withhold or withdraw life-sustaining therapies for our loved ones. Nothing can make this decision easy, but there are ways to ease the enormous burden we all feel when faced with this terrible question. In critical and chronic disease, thinking about these inevitabilities can only serve to help ease this decision-making later on. Doing all we can for loved ones may not always mean continuing aggressive care. In fact, it may be quite the opposite.
End-of-life decision-making occurs in the face of the potential loss of someone that a family loves very much, some precious person. And so it's going to be difficult, but it doesn't need to be as difficult as it sometimes is. And the way to make it less difficult, in my mind, is to have very open communication between the ICU team, all other caregivers involved in the patient's treatment, and the family. If a family feels that all appropriate treatment has been provided and that further application of ICU treatment or technology will not yield benefit for the patient, then the decision is clearer and there's less agony in making it. And the only way for a family to feel this way is if there's ongoing communication between the ICU team and the patient and the family.
There are many times in the care of patients where we as healthcare professionals reach a point where our technology is not helping them. And there are often questions about how we ought to proceed. Should we continue these therapies? And from a perspective of a family member, I think the question is, what is the goal? What are we trying to achieve? And if these technologies are only prolonging the dying process, then we're not obligated to continue those. And I think that for family members, it is important for them to realize that just because we've started a technology doesn't mean that we have to continue it if it's no longer benefiting the person.
In the setting of withdrawing life-saving treatments, it's very important that that family members have good communication with the clinicians. It's very important that issues of symptom control be attended to. When we take away, for example, ventilators, we want to make sure that we give patients adequate medication so that they're not going to be short of breath. And it's very important that we communicate with family members about what's going to happen after that life-sustaining treatment is withdrawn. How long patients may survive, what that dying process may look like, and what we're going to do to make sure that it's comfortable for the patients.
I think what is absolutely essential is that we communicate to the loved ones of this patient that withholding and withdrawing life support does not mean that we are withholding care. Every patient in an intensive care unit requires and needs and deserves aggressive care. The question is, what do we mean by aggressive care? It may be aggressive technological care at one point, and it may be aggressive comfort care along the way. So withholding and withdrawing life support does not mean we are abandoning the patient and not recognizing their needs as they are dying.
Many people have a limited view of what's possible at the end of life. So when we have really exhausted our technology in attempts to try to cure someone, to try to turn around their disease process, people perceive that there's nothing else that can be done. And in fact, there's a lot that can be done. And one of the areas where I think the public can really advocate successfully is in the area of pain and symptom management. We have a wonderful array of technologies and skills that can be brought to bear on treating a person's pain and symptoms. And often families aren't aware that they have that as an option to advocate for.
Many people are very concerned about what kind of care is going to be provided to them and to their loved ones at end of life. What is in the minds of a lot of people is that dying will be painful and lonely. I think what's important for many people to know is that we have many, many more interventions and a much greater knowledge of how to keep people comfortable. Dying does not have to be painful, both physically and psychologically, and we do have the knowledge and the skills as clinicians to promote comfortable dying for patients, and I think that's important for family members to know.
So why are we talking so much about end-of-life care? Why force ourselves to deal with these difficult, painful questions about death and dying? What is to be gained from all of this questioning and searching? The goal is so very simple: to provide a caring, compassionate environment in which every patient and their loved ones may go through the dying process.
Although there's a sense of loss at the end of life and grief about the loss, there are opportunities for a positive experience even at the end of life and even in the setting of an intensive care unit. If a death is occurring at a time when it is clear to everyone involved in the process that there is no benefit to giving any further treatment oriented toward life prolongation, then there is a sense of acceptance, a feeling that all appropriate care has been provided.
The transition from aggressive to palliative care, again, should be seamless as much as possible. And the only way to do that is for all people to have in mind that it may come to such a transition, and when the transition comes, to discuss it as fully as possible.
It's important for individuals and families to consider what would be the goals for this type of care. What will be the endpoints? What do we want for our loved one? We know that we will have to say goodbye. What kind of a goodbye do we want to say to them? We want them most often and most always to be as comfortable as possible. Sometimes providing comfort care conflicts with providing aggressive care. Now, we would hope that that's not the case, but sometimes that is the situation. So I think it's important for a family member to ask themselves, or family members to ask themselves, what are the goals and what can I give to my loved one? What is the last gift that I can give to my loved one? And if that is promoting their comfort, their physical comfort, promoting a peaceful death, a good death, then that might be the best gift that we can give for them.
Death in the ICU doesn't have to be a painful and uncomfortable thing. I recently took care of a 75-year-old man. He was healthy and well prior to coming into the hospital. His wife used to joke that he would get up every day and pester her with, what were they going to do, where were they going to go today, what were they going to see today. He was in a car accident and had a fracture of his spine and wound up quadriplegic, being unable to move his arms or his legs. And in fact, he was unable to come off the ventilator. He couldn't breathe on his own. We had a number of discussions with the family. They decided that he would not want life support. He wouldn't want to live on a ventilator, unable to move his arms or his legs. And so we took the ventilator away. He was able to talk to us for a while. He had enough respiratory function that he was able to breathe for about an hour. And he spent that hour with his family, talking with them, joking with them, saying goodbye. One of his requests to us was a glass of red wine, and one of the physicians went out to a local store and bought a bottle of red wine and brought that in for him. As he began to tire and began to get a little uncomfortable, he let us know that. We gave him enough morphine to make sure he was comfortable, and he died peacefully after being able to spend an hour saying goodbye to his family. It was really a remarkable experience for the physicians and nurses who were taking care of him, and it was a very positive experience for his family. They felt like he got the care he would have wanted, and he got the opportunity to say goodbye to them.
If I were giving suggestions to family members about how to participate in a loved one's end-of-life care, what I would say is that the important part of end-of-life care is really being with that person, to be able to spend the time with that person and to get some kind of closure on that relationship. Ira Byock talks about the things that every dying person need a chance to say. One is that I forgive you, I ask for your forgiveness, I love you, and goodbye. And those are tasks that every dying person need to have the opportunity to do. And family members also need the opportunity to get some closure, to say the important things that they want to say to that person, and to feel as if at the end of the process that they can live with their participation in that process, and that they can go on with the rest of their lives in a healthy grieving process.
Losing a loved one is without question the most difficult challenge any of us will likely face in our lifetimes. But as we have seen, this is a task that we need not face alone. I urge you, when confronted by the potential loss of a loved one in the ICU, to gather your family together, to consult with your personal physician, and to initiate conversations with intensive care unit physicians and nurses. Ask all of your questions, talk freely, and express your feelings openly. By working together, we can create an environment for patients at the end of life of comfort, genuine kindness, and compassion.